On the basis of this and several other trials, most pulmonologists recommend antibiotics to any patient with either two of the three cardinal symptoms or a severe enough exacerbation to warrant positive pressure ventilation. But which antibiotic to use? This choice depends on four factors: the severity of exacerbation, the likely pathogen, risk factors for poor outcome, and your institution's specific antibiotic resistance profile. Here's a chart I've compiled based on a combination of professional society guidelines and antibiotic resistant patterns found at my home institutions of the Palo Alto VA Hospital and Stanford Medical Center. With mild exacerbations and no risk factors for poor outcome, the major pathogens to worry about are going to be strep pneumo, H. flu, and Moraxella. I would consider azithromycin to be my first choice antibiotic. Acceptable alternatives include cefpodoxime, which has unnecessary gram-negative coverage and misses atypical coverage, and doxycycline, which suffers from increasing resistance to it from pneumococcus. With a moderately severe exacerbation or with risk factors for poor outcome, in addition to the above pathogens, we also need to worry about various gram-negative rods. Therefore, our antibiotic coverage needs to be broader. First line is amoxicillin clavulanic acid, commonly known as Augmentin. Second line treatment would be the respiratory fluoroquinolones moxifloxacin and levofloxacin. Lastly, with a severe exacerbation or in patients with risk factors for pseudomonal infection, you need to be even broader. What are risk factors for Pseudomonas among patients with COPD? There are four to remember. Hospitalization within 90 days, FEV1 less than 50% predicted, a previous sputum culture with Pseudomonas, or 4 or more courses of antibiotics within the past year. First-line treatment for these patients is pip/tazo, commonly referred to as Zosyn. Levofloxacin is an acceptable second-line agent. How long do we treat these patients with antibiotics? A meta-analysis of 7 RCTs, including over 3,000 patients, compared a 5-day course with a 7 to 10-day course in outpatient COPD exacerbations. As you can see, the risk of treatment failure was identical in both groups. However, the risk of drug-related adverse events was less in the short course. Therefore, 5 days of antibiotics is the preferred duration of treatment. Although, again, the study was done in only outpatients, it is certainly possible that patients requiring inpatient admission are sicker and might potentially benefit from longer courses. This is probably a good place to make the very important note that when I am discussing antibiotic selection and duration, I am referring only to those patients with a COPD exacerbation in the absence of clinically apparent pneumonia. If your patient has a clinically relevant pneumonia, that is a fever, elevated white blood cell count, and infiltrate on chest x-ray, then he or she should be treated with antibiotics according to the pneumonia guidelines. Now let's move on to a couple other important management issues. Specifically, inpatient oxygen therapy, non-invasive positive pressure ventilation, and concurrent pulmonary embolisms. First, oxygen therapy. There's a well-known association between high arterial oxygen levels in COPD patients and the development of hypercapnia. The classic scenario is one where a patient with baseline hypoxia presents to the ER with a modest COPD exacerbation and is reflexively placed on high amount of supplemental oxygen, only to become confused and somnolent 15 minutes later, at which point an urgent ABG confirms the presence of significant hypercapnia. This occurs as a consequence of 3 independent mechanisms. Probably the most important is the overcoming of hypoxic vasoconstriction leading to worsened VQ mismatch. The Haldane effect is also a contributing factor. Lastly, in patients with chronic carbon dioxide retention, there is a largely unproven hypothesis that ventilatory drive becomes dependent solely on the presence of mild hypoxia. when this hypoxia is corrected, the stimulus for the patient to breathe disappears. Because of all these factors, most experts recommend targeting an O2 saturation of around 90 to 92% in patients who are hypoxic. Non-invasive positive pressure ventilation is another important treatment modality to consider for patients with a COPD exacerbation, specifically BiPAP. Here's a picture to remind you of what this device looks like. It's essentially a tight-fitting mask that delivers oxygen-rich air under pressure, improving both the patient's oxygenation and ventilation. Some BiPAP masks fit over just the nose like this one, while others fit over the nose and the mouth. While it may look silly, and these masks are not known for being particularly comfortable, BiPAP can be a very effective way to drive down carbon dioxide levels. Exactly how effective is BiPAP? In a meta-analysis published in Chest in 2008, 14 studies were examined in which nearly 1,000 patients with COPD exacerbations were randomized to either BiPAP or standard care. The meta-analysis demonstrated that BiPAP significantly cut the risk of the patient eventually requiring intubation, with a relative risk less than half that of standard care. By nearly an equal margin, it decreased the risk of in-hospital mortality, and on average, decreased length of stay in the hospital by nearly 2 days. The benefit of BiPAP was shown to be really quite dramatic. I'll apologize that this next graph may seem excessively busy. However, essentially what it demonstrates is that the reduction in the risk of intubation was closely related to initial arterial pH. In other words, if the initial arterial pH was normal, there was no benefit from BiPAP. But the benefit was more pronounced the lower the pH was. The authors of the study didn't provide a specific cutoff, but from eyeballing the graph, it appears to be about 7.35. In other words, the lower limit of normal. Thus, here is another reason why most patients sick enough to be admitted to the hospital weren't having an ABG checked. It will help decide who should receive BiPAP. The probable link between COPD exacerbations and pulmonary embolisms didn't become widely recognized until 2009, when a meta-analysis of 5 separate studies found that the prevalence of PEs in patients with exacerbations of spirometry-confirmed COPD was 20%. This number was astonishingly high. I don't think anyone knew quite what to do with the information. Does this suggest, for example, that every patient with COPD needs a CT angiogram on admission? And what was the explanation for this observation? There are 3 basic explanations. 1, PEs can trigger COPD exacerbations, just like pneumonia and air pollution do. 2, COPD exacerbations promote the development of DVTs. Or 3, my preferred explanation is that these patients don't have a COPD exacerbation at all, but that the PE's symptoms and signs are being mistaken for such. That PEs can trigger things like cough and wheezing are definitely underappreciated. Well, okay, regardless of pathophysiologic explanation, how do we determine which patients are at higher risk of having a PE? Of the 5 studies included in the aforementioned meta-analysis, 1 study showed that patients with PE were more likely to complain of chest pain and less likely to complain of cough or increased sputum production. Unfortunately, the other 4 studies showed no difference in symptoms. None of the studies showed differences in exam, EKG, or chest X-ray findings. 1 study found an average initial PaCO2 that was 5 millimeters of mercury lower than baseline in patients with PE, but this required patients to have baseline ABG, which in practice most don't. Lastly, 1 study found that patients with PE were more likely to have active malignancy or prior venous thromboembolism. Using all this information, here I've created a simple algorithm that I would like to propose for deciding which patients with a COPD exacerbation warrant workup for PE. First, Does the patient have a history of malignancy or prior venous thromboembolism? If yes, then they need to be evaluated for PE. If not, what is the nature of the presentation? If it is atypical, for example, that is, it is characterized by very abrupt onset, no cough, a clear chest x-ray, pleuritic chest pain, and a lower than baseline PaCO2 if known, then that patient needs to be evaluated for PE. If the presentation, on the other hand, is typical, then just treat for COPD. If the patient does not rapidly improve, keeping in mind that almost all COPD patients feel better within several hours of treatment, at that point, evaluate for PE. However, if they do improve, and as they had a typical presentation, they are unlikely to have PE. Now we have just about exhausted the major components of the diagnosis and management of a COPD exacerbation. How do we know when a patient is ready for discharge? There is no absolute criteria, but things to consider include: are the patient's symptoms improved? Has the patient been on oral meds for at least 24 hours? Is the patient's oxygenation back to baseline? And is the patient able to ambulate without difficulty? Keep in mind, most patients will be appropriate for discharge before they feel like they are back to 100%. A couple of last thoughts prior to discharge. Anyone who is still smoking absolutely requires smoking cessation counseling. Does the patient require home oxygen? Most insurance companies require a patient to have a room air O2 sat of 88% or less in order to qualify for home O2. Finally, you should make sure the patient's vaccinations are up to date, specifically the pneumococcal and influenza vaccines. The importance of these often neglected issues cannot be overstated. Remember that smoking cessation and home oxygen for those who qualify are essentially the only major treatment modalities that have been shown to improve long-term survival in patients with COPD. All of the maintenance meds we prescribe for stable COPD only improve symptoms. They don't make people actually live longer. Alright, I've given you a ton of information and data, and I suspect you may be having trouble remembering it all. So here is a brief summary of the key points I've talked about. Diagnosing a COPD exacerbation is based on having an acute change in a patient's cough, dyspnea, or sputum production and/or purulence. Regarding management, albuterol and/or ipratropium should be prescribed for everyone, though good evidence is not available. If a patient is able to use good technique, an inhaler is just as good as a nebulizer. Otherwise, go with a nebulizer. Regarding steroids, just about everyone should get them. Oral prednisone is adequate for most patients, keeping in mind that while a patient is on continuous BiPAP, he or she should be NPO. The recommended prednisone dose is 30 to 60 milligrams for anywhere between 5 and 14 days, with or without a taper. Antibiotics are indicated if at least 2 of the 3 cardinal symptoms are present. Selection is based on likely pathogens, severity of exacerbation, risk factors for poor outcome, and local resistance patterns. A 5-day course may be as good or even better as a longer course. For hypoxic patients, you should aim for keeping an O2 sat of around 90 to 92%. BiPAP reduces the need for intubation, improves mortality, and decreases hospital length of stay. The benefit is more pronounced with lower initial arterial pH. And finally, a PE should be considered as either an alternative or additional diagnosis when risk factors are present, presentation is atypical, or if the patient fails to improve with COPD therapy. Thank you for listening. I hope this lecture has been helpful. Once again, this was Eric Strong of the Palo Alto VA Hospital and Stanford University. For more information about the diagnosis and management of COPD, I recommend visiting the website www.goldcopd.org.